Hi, everybody. Welcome to EMT 274, Week 2. My name is Jason Ramsey, and I will be helping out with some of the lecture material and then for the second part of the class, some of the lab material. I am the Director of Clinical Education for the Respiratory Care Program at KVCC, and so I will probably know some of you when lab time comes around. Um, I'm very grateful to have been given this opportunity by Dan Bernard, and I'm anxious and excited to kind of get through this stuff with you guys. So you'll be hearing a lot from me apparently because it's it's a lot of recorded lecture material, and recording lectures is kind of a first for me. I'm used to doing everything in person, so bear with me. I'll work out any kinks that there are, and hopefully it's not like horribly boring. But I will do my best to get you guys through it. So this class, Dan, you know, it was Dan's idea to get this class up and running. And I really think it's a fantastic class for KVCC to have. Critical care transport is so incredibly important. To have a certificate for it. That is awesome. Little bit of background from me. I've been a respiratory therapist for, gosh, I don't know, 17, 18 years or so. I've been in the clinical director role here at Valley for the last four. Prior to that, I managed the RT department at Borges, now Beacon, in Kalamazoo, all through COVID and things like that. But my bedside experience was primarily in the neonatal ICU, so the NICU, and transport. And my favorite part of bedside was transport. So I was transport certified, or am transport certified in ground and flight, both rotary, which is helicopter, and fixed wing, which is airplane. And I mean, talking to a screen, talking to a light on the top of my laptop is kind of funky. But when I see you guys in lab, I'd be happy to tell you, stories that I've had over time. Just crazy stories for for critical care transports, for neonatal, for pediatrics, and yeah, I mean my passion is there. So I was stoked when Dan kind of called on me to help with some of the content for this course. So without further ado, I suppose, since you will get tired of my voice, I promise. Um, so the first lecture for this week, and there are four of them. It's on airway anatomy and physiology, and it's basically a review. So today we're going to do a focused review on airway anatomy and physiology, specifically for critical care transport. You guys already know basic A&P. My goal is to reconnect that knowledge to real transport problems like hypoxia, poor ventilation, aspiration risk, tube depth, and sudden deterioration during movement. So everything we cover here will feed directly into our next sessions on airway assessment, airway management, and next week ventilator strategies. So I appreciate everybody taking the ride with me, so to speak. So any kind of transport, specifically critical care transport, requires a mastery of the airway. And I know most of you are either paramedics or EMTs or nurses or even respiratory therapists, but to have a little refresher is a good thing. In transport, airway issues are amplified by the environment, much more so than in the hospital setting. Um, we're working in cramped spaces with movement, sometimes with elevation, with vibration, with noise, and most importantly, with limited help. A mildly compromised airway in the ICU can become a major problem once we start moving the patient. So as we go through the anatomy, I want you to think, how will this behave in the back of the ambulance or the helicopter or the airplane when the lighting is poor and the access is limited? Um, but basically, this slide is more of a like why this matters. So, transport clinicians manage airway and respiratory failure in confined, mobile, and interruption-prone environments. Normal anatomy becomes operationally important when you've got issues like edema, blood, emesis, secretions, packaging, and movement, all of which complicate care in the mobile environment. Airway structure influences positioning, adjunct use, suctioning, intubation view, tube depth, resistance, gas exchange, etc. Physiology then explains why patients decompensate, and we'll look at airway obstructions, bronchospasm, fatigue, alveolar collapse or atelectasis, shunts versus dead space, VQ mismatching, increased work of breathing, and things of that nature. Our learning objectives for this unit, and I hate reading off of slides, so this is going to be tough for me, honestly. I'm used to being at a whiteboard and writing everything down, but I will do my darndest to not just read from slides, but some, like the objectives, kind of require it. So, what are we going to learn in the next few minutes? We're going to differentiate between the upper and lower airway and describe the function of each major structure. We'll relate airway anatomy to humidification, filtration, phonation, protection, airflow resistance, secretion clearance, lots of fun stuff. We'll explain how the tracheobronchial branching and alveolar structure support ventilation and gas exchange. And we'll also apply normal anatomy and physiology to transport problems such as obstruction, aspiration, bronchospasm, atelectasis, and difficult ventilation and or intubation. Each of the different parts of the anatomy for this presentation will be divided into sections. So section 1 is the upper airway review. When we're talking about the airways, I want you to think about the airway as being two big parts, the conducting zone and the respiratory zone. The conducting zone conditions and delivers air, but it does not exchange gas. The respiratory zone, starting at the respiratory bronchioles and the alveoli, is where oxygen and carbon dioxide actually move between air and blood and into the bloodstream. As we go through diseases in this course, I want you to ask yourselves, is this mainly a conducting problem, so resistance and flow, or is it a respiratory zone problem, so compliance and gas exchange? So the conducting zone, or the upper airway, that consists of the nose, the mouth, the pharynx, and the larynx, and direct inspired gas. The primary roles are filtration, warming, humidifying, and airway protection. For the lower, the respiratory zone, we've got the trachea, the bronchi, bronchioles, all the tracheobronchial tree, respiratory bronchioles, alveolar ducts, alveoli, the AC membrane, the acinus, all those things. So the conducting airways move gas into the distal lung, and the respiratory zone is where the exchange between oxygen and carbon dioxide occurs. All right, so let's go from top to bottom. So we'll start with the upper airway, which consists mainly of the nose, the oral cavity, and the pharynx. The nose is our best route for normal breathing because it warms, humidifies, and filters the incoming air. In emergencies, though, we're often forced to inhale through the mouth, which is faster, but it doesn't condition or filter as well as the nose does. The pharynx is a shared pathway for air and food. It's just soft tissue. There's no rigid support. So when muscle tone drops, the pharynx collapses. That's why an obtunded or a sedated patient suddenly starts snoring or obstructing. In transport, that's our cue for positioning, first and foremost. So jaw thrust, head tilt chin lift, if indicated, early use of OPAs or oropharyngeal airways or NPAs, nasopharyngeal airways, plus aggressive suction if there's anything there that's obstructing, like blood or vomit or things like that. Um, so the nasal cavity and the turbinates increase surface area to warm, humidify, and filter inspired air. The oral cavity provides an alternate route with less conditioning and less filtration. The pharynx is shared by the respiratory and the digestive tracts, creating a built-in aspiration challenge. Aspiration, of course, is bad. The nasopharynx, oropharynx, and laryngopharynx are vulnerable to soft tissue collapse and secretion pooling. That is absolutely true. And then loss of muscle tone can rapidly convert a normal upper airway into an obstructed airway, similar to how atelectasis can cause a consolidation or constriction in the lungs. And I know this is all review, but a good review, I hope. So let's go to the larynx next. So the larynx is what I like to call the gatekeeper of the lower airway. It's the gatekeeper to the lungs themselves. The epiglottis and the vocal cords protect the lower airway from aspiration, but they also control airflow and create resistance. When this area swells or spasms, like an anaphylaxis, thermal injury, or post extubation edema, we hear stridor and see a big increase in the inspiratory work of the patient. This is very different from a lower airway wheeze. If you hear stridor in a transport patient, that's a don't wait problem. We need to be planning on advanced airway insertion before it progresses to a complete obstruction. So the larynx, key structures comprised of the epiglottis, the glottic opening, the vocal cords, thyroid and cricoid cartilage, the subglottic region that leads into the trachea, and why it matters, and it's very important that it protects against aspiration, controls airflow and resistance, supports cough and phonation, and it creates a high risk site for edema and obstruction. Next, we'll get into the lower airway from the trachea to the alveoli. All right, so once we pass the larynx, we're in the trachea. The trachea is a relatively rigid tube supported by cartilage rings. At the carina, the airway splits into the right and left mainstem bronchi, which you all know. The right main bronchus is wider, shorter, and more vertical, which is why both aspiration and unintended mainstream intubation tend to go to the right. So I don't know if you can see the overlay mouse here, but we always talk about right mainstem versus left mainstem. Left mainstem being almost not a thing. Just the directional flow of the catheter as it passes. Um, Once past the carina, will go into the right main stem. Um, the right main stem, or the right main bronchus, I'm sorry, is both wider and shorter, and more vertical. So it definitely helps to facilitate that whole directional flow. In transport, if a patient suddenly loses left-sided breath sounds or their oxygenation drops after you move them, one of the first things you should check is the tube depth and listen to the lungs, left first and then right, to see if there's any kind of suspected right main stem intubation. Remember the head chain or the head position changes, and any movement, from bed to stretcher or from just side to side, that can shift the endo tube, even if it is placed properly and secure. So you always want to double and triple check the airway placement. So the trachea is a conducting airway supported by C-shaped cartilage rings that maintain patency. The posterior tracheal wall is membranous and lies adjacent to the esophagus. At the carina, the airway bifurcates into the right and the left main stem bronchi. The right is wider. We went over this. It's exactly. The branching then continues into lobar and segmental bronchi, all the way down to terminal bronchioles, which we'll get into, and finally the alveoli and places for gas exchange. Once past the main tree, as we go further um, into the lungs, as we go more distal into the lungs, the airways get smaller and they also get much more numerous. When we get to the bronchioles do not have any cartilage, so they're very sensitive to smooth muscle tone, inflammation, and edema. That's why asthma and bronchiolitis cause such big changes in airflow and have such a tremendous effect on certain populations, especially pediatrics and neonates. The terminal bronchioles are still just moving gas, but the respiratory bronchioles, the alveolar ducts, and the alveoli add gas exchange surfaces to the equation. By the time we get to the alveoli, we're not talking about airflow anymore. We're talking about diffusion across an extremely thin membrane, the AC membrane, the alveolar capillary membrane, where oxygen and CO2 transfer. One of the main things, as you know, with the treatment and management of airway in general, and with specific respect to airway physiology, is the mucociliary system, specifically the clearance system, the airway defense system, um, and it, I don't know how much you guys would have gotten in EMT with regards to this. We go into it in quite a bit of detail in RCP, but the airway protects itself with mucus and cilia. Particles get trapped in the mucus, and cilia move the mucus up toward the pharynx, where it can be swallowed or coughed out. Cough is our backup system when secretions get deeper or thicker. In transport patients specifically, things like dry oxygen, fever, dehydration, smoke, or even long-term intubation can shut this system down, leading to heavy, stagnant secretions. If we don't manage those with suction and humidification strategies, we end up with increased resistance, mucus plugging, worsening oxygenation, worsening ventilation, all mid-transport, and that's not what we want. So we'll go into this in more detail in the suctioning section later on in one of the lectures coming up. Um, but for now, let's focus on this mucociliary system real quick. So the ciliated respiratory epithelium and mucus trap inhaled particles and move them up toward the pharynx. Coughing provides a backup clearance mechanism when secretions or foreign material reach the lower airway. Humidification preserves secretion mobility. Dry gas thickens secretions and impairs clearance. Airway instrumentation can bypass, blunt, or overwhelm normal defense mechanisms, and that's really important. Like when we get into um, the adjunct airways in I believe the next lecture. Um, and then in transport, poor secretion control can rapidly worsen airway resistance, oxygenation, and ventilation. In other words, it will make your shift a living hell. All right, section 3 will focus on airflow and gas exchange and how the airway radius, compliance, alveolar stability, and diffusion determine whether oxygen actually reaches the blood where it's supposed to. All right, as we go further in this course, when we talk about mechanical ventilation, things like that, the physics of airflow is actually very important, and I won't gloss over it because it, it's something that like everybody who is dealing with intubated patients needs to understand. The one key idea is that small changes in airway diameter, just tiny changes in the airway diameter, can create huge changes in airways resistance. That's why a little edema or a little mucus in a pediatric airway or a small amount of swelling around an endotracheal tube can have dramatic effects on the patient and their whole the whole process. Clinically, you'll feel this as being harder to bag valve mask ventilate. You'll see rising peak inspiratory pressures, rising PIPs on ventilators. We'll get into that, I believe, next week. You'll hear more wheezing. You'll see a more prolonged expiration or exhalation in patients. So anytime a patient becomes harder to bag suddenly, or their pressures climb, I want you guys to think, what just narrowed their airway? Was it edema, swelling? Was it bronchospasm? Is there a kink in the tubing? Do they need to be suctioned? Are there secretions? Things like that. So key principles. So airflow becomes harder as airway radiuses decrease. Edema, bronchospasm, secretions, blood, any other fluid, any kinking in the tubing, um, increase resistance. Turbulent flow increases work of breathing and the pressure needed to move gas. And then consequences for transport, it's harder to bag, you get higher PIPs. There's incomplete exhalation on the expiratory phase, so you get air trapping or auto PEEP. And then obviously worsening fatigue in a spontaneously breathing patient. They're, not going to be able to breathe through those thin airways for long. I wasn't sure whether to put this here or save it for the mechanical ventilation lecture, but I think with regards to physiology, it's important to have a basic understanding of these things before we get further along. Um, and so at risk of being, redundant, let's talk about breathing mechanics. So compliance, elastic recoil, work of breathing, airways resistance, things like that. So compliance, airway compliance, so lung compliance is how easy it is to inflate the lungs and the chest wall. Elastic recoil is how well they spring back into place to help you exhale. Obstructive issues or diseases like asthma and COPD mainly affect the exhalation piece. So patients are often wheezy with like prolonged expiration. Um, it leads to hyperinflation, it leads to air trapping, easy to get air in, harder to get it out. Um, Restrictive diseases, on the other hand, hard to get air in, easy to get it out. Lots of elastic recoil with restrictive diseases, ARDS, pulmonary fibrosis, things of that nature. Um, so when we talk about compliance, and this is a whole lecture on, in and of itself, but compliance is how easily the lungs and the chest wall expand. Low compliance means a stiffer lung or harder to get air in, um, and um, harder to inflate. Elastic recoil supports passive exhalation and helps to preserve normal ventilation patterns. Um, Obstructive problems increase resistance. Restrictive problems usually reduce compliance. Many critical care patients have both. Um, as work of breathing rises, respiratory muscles fatigue and ventilatory failure can follow. So basically, like if you're not well versed in compliance and resistance, we will go over that more down the road. Um, but the last point is kind of the key takeaway here. So like transport clinicians should distinguish between being hard to ventilate because of resistance versus a patient being hard to ventilate because of poor compliance, and we'll go into that a lot more um, down the road. All right, so we're finally to the gas exchange portion of our program. The alveoli and the AC, or the alveolar capillary membrane. The alveoli, as you know, are where the whole system cashes out. This is where oxygen enters the blood and carbon dioxide leaves it. The AC membrane is extremely thin to allow diffusion, but that also makes it very vulnerable to fluid, inflammation, fibrosis, and all like other myriads and hosts of issues. Um, if the alveoli are collapsed, known as atelectasis, or they're filled with fluid, or they're poorly ventilated, or they're poorly perfused, ventilation, perfusion, dead space, things like that. Your patient's PaO2, the P small AO2, is going to suffer no matter how open the upper airway is. So later, when we look at ABGs, I want you to think back on this slide. So low PaO2, despite decent ventilation, usually means a problem at or beyond this membrane. So pneumonia, edema, ARDS, big time VQ mismatch, things like that. And honestly, this is so hard for me to just speak into a computer because I constantly do call and response. in class. I ask a ton of questions, and I can't ask you questions because you're just sitting there with headphones on or in your car listening. So I apologize for that. But I guess with that said, I guess we're 30 minutes into the first lecture for crying out loud. But um, my contact info is in Canvas. My email jramsey@kvcc.edu. You're welcome to email me at any time. My cell phone's at the bottom of my email signature. You're welcome to text me at any time. If you have any questions about any of the material that I cover in this class, please, by all means, reach out, and I'll be happy to clarify anything for you. Um, anyway, back to the slide. So alveoli are the terminal exchange units of the lung and number in the hundreds of millions in healthy adults, which is crazy. The alveolar wall lies closely opposed, that's spelled wrong, to pulmonary capillaries, minimizing the distance for the actual diffusion to take place. The oxygen, of course, moves from the alveolus to the blood, while the carbon dioxide moves from the blood to the alveolus so that we can exhale it. And effective gas exchange requires an open alveoli, adequate ventilation, adequate perfusion, and an intact membrane. Any of those things can impair gas exchange if they are impacted negatively at all. I'm curious to know, and I guess I can ask a question to the ether. Do you guys know about VQ mismatch? Perfusion versus ventilation, dead space, things like that. I can't even do a call and response and like have you do the things in the chat. That's annoying. But if you want to shoot me an email or anything, if you're interested at all, please do anytime, and I will respond back ASAP. So we've worked our way down from the upper airway to the lower. We're now in the alveoli still, and so let's take a minute to talk about alveolar stability. So that mainly impacts surfactant and atelectasis. So let's start with surfactant. Surfactant is the substance that lowers surface tension inside the alveoli, keeping them from like snapping shut at the end of an exhalation. When surfactant is reduced or inactivated, the alveoli collapse more easily, atelectasis, um, and as a result, compliance drops, and it takes more pressure to reopen them. Clinically, that means it's harder to ventilate them and harder to oxygenate them as well. In neonates with surfactant deficiency, this is a little more obvious, but adults can have functional surfactant problems as well, specifically in ARDS, for pain control, low PEEP strategies, and things of that nature. So in the transport environment, every time we disconnect a vent or remove a BVM from a patient that we're bagging with a PEEP of 5, 8, or 10, um, we risk losing alveolar stability. Um, Surfactant by nature lowers alveolar surface tension and helps to keep alveoli open during or at lower lung volumes. Reduced surfactant contributes to alveolar collapse, reduced compliance, increased work of breathing. Atelectasis decreases available exchange surface and worsens oxygenation. And this concept matters in neonatal transport specifically, but it is not to be not to be slept on in other patient populations as well. So if you're the whole concept of compliance and resistance, I won't get into it a lot right now, but um, compliance is how easy, where's my camera at? How easy a lung or the distal lung unit opens and closes. Okay. If it's collapsed, surface area is gone, atelectasis, etc. If it's stiff or there's increased resistance, so scarring, fibrosis, ARDS, pulmonary edema, things like that, makes it harder to ventilate. Ventilatory control and the control of breathing. I just want to touch on this briefly. Your brain stem sets a basic breathing rhythm, and the chemoreceptors and mechanoreceptors modify it based on a number of different things. So carbon dioxide, pH, oxygen, your stretch receptors, metabolic demand, all stuff that's like way over my head even. The important point, though, is that a strong drive to breathe doesn't guarantee adequate ventilation if the mechanics themselves are poor. So when you see somebody breathing very fast and hard, tachypnic, maybe hyperventilating, maybe Kussmaul's breathing, ask yourself, is this a primary drive problem or is it a compensation for something like metabolic acidosis or stiff lungs or something along those lines? That distinction alone will come back when we talk about ABGs in a little bit, and when we decide who needs ventilatory support. So in terms of the control centers, we've got the central control or the central chemoreceptors, peripheral input or peripheral chemoreceptors. For central, that's the brainstem. Centers, they generate the respiratory rhythm. Carbon dioxide is a major driver of the ventilatory response through pH effects. As far as the periphery goes, chemoreceptors, mechanoreceptors modify the pattern and the effort of the breathing. And things like hypoxemia, your stretch receptors, irritation, metabolic demand, all alter breathing behavior. Section 4, clinical failure patterns. So applying normal anatomy and physiology to obstruction, aspiration tube problems, so ET tube problems, secretions, and alveolar disease. Clinical application for upper airway failure patterns. So let's classify upper airway failure by mechanism. Soft tissue obstruction shows up as snoring or absent airflow in a decreased consciousness patient. That's a positioning and adjunct problem. Edema, so swelling, could be from anaphylaxis, or burns, or infection. Those all can produce a stridor effect and a rapidly increasing work of breathing and early intubation consideration from an upper airway issue. Um, Other things like blood, vomit, teeth, foreign bodies, really anything can cause a gurgling and visible contamination. That is a suction and an aspiration risk problem. Loss of protective reflexes, like a serious head injury, overdose, those mean the patient can't protect themselves from aspiration at all. And that's when we need to be thinking about definitive airway protection sooner rather than later. Clinical application for lower airway and alveolar failure patterns. So shift your thinking a little lower. At the airway level, bronchospasm, mucus plugging, air trapping, or a main stem tube are they primarily increase resistance and impair ventilation. At the alveolar level, atelectasis, pulmonary edema, pneumonia, ARDS, those primarily impair oxygenation and compliance. So when a patient is hard to ventilate and they're wheezy with a prolonged exhalation, I want you to be thinking about lower airway level problems. When they're stiff or hard to inflate, hypoxemic due to despite high FiO2s, think alveolar level problems. In many critical care transports, you'll see combinations of both. As we're close to wrapping up this one, let's take a little sidetrack to anatomy as applied to the airway devices that we'll be going over a little bit later. So every airway device you use is designed to solve a specific anatomical problem. So you've got OPAs and NPAs. OPA, oropharyngeal airway, NPA, nasopharyngeal airway. Those primarily target the upper part of the pharynx in terms of patency. Um, OPAs and NPAs, they hold soft tissue away from the posterior pharynx in order to keep the upper airway open. They just offset the soft tissue obstruction and help to maintain passage for gas to be able to move. Supraglottic devices like your iGel, King Airway, Combitube for those of you who are older school like me, LMAs, things like that. Those create a seal above or around the laryngeal inlet, and they bypass the pharyngeal collapse, but don't put the tip into the trachea. So they're basically just, and you know this, you blind insertion, shove it in until you hit resistance, pull back a smidge, um, inflate if there's anything to inflate, connect the bag, and go to town. um, let's see, endotracheal tubes, of course, they live in the trachea above the carina. If they're too shallow, they're easy to dislodge. If they're too deep, then they often end up in the right main stem, etc. Suction, of course, then clears the pharynx and the trachea of anything that's not supposed to be there. Blood, vomit, secretions that otherwise increase resistance and an aspiration risk. So when you choose a device, ask yourself exactly which anatomic problem am I trying to fix? So you slogged through a 43-minute A&P review, and I mean, if I could buy you guys all coffee or lunch or something for, for suffering through that, I would, and I will. Hold me to it. Hold me to it. For those of you who have gotten this far, and you remember this part, remind me. First day of actual lab for the um, second block of this class. I'll bring you guys in something. But anywho, transport case discussion. So let's apply it. So we've got an intubated pneumonia patient who becomes harder to ventilate after transfer to the stretcher. SpO2 falls from 96% to 88%. Peak pressure rises. Right breath sounds are much louder than the left. I mean, that's pretty self-explanatory. But if you're going through, and assessment comes next, but Think about these things. Think in these terms. So, what airway structure is most likely involved? How does a normal bronchial anatomy explain the change? What immediate assessments and corrective actions should you follow? And how would the physiology differ if the problem were mucus plugging instead of what you assume to be a right main stem intubation? Finally, to the end of the first kind of pilot, um, trial run, whatever you want to call this. Key takeaways for this review session. So the upper airway conditions gas and protects the lower airway, but it's structurally prone to collapse and contamination. The lower airway is what conducts gas, then transitions to alveolar structures built for diffusion. Resistance problems and compliance problems feel different and should trigger different clinical thinking. I mean, you'll get much more of that as we go along. Right mainstem anatomy, secretion burden, airway edema, alveolar collapse all have predictable transport implications, and we'll get into those down the road as well. And then strong airway care begins with understanding where the problem is occurring and what that does to ventilation and oxygenation. Um, so I appreciate you guys getting through this, and I will hopefully be more efficient and flowy with, future presentations like this. And man, it's tough. I wish I feed off of students, man. Like I have to have the interaction. So this is as awkward for me as it is for you. But I thank you. All right, next up.